morning. What a pleasure it is for me to be with you all pediatricians and nurses from Sweden and around the world. For those of you who have been in Rwanda, you will know why it is known as the land of thousand hills. My beautiful home is located in sub-Saharan Africa. It is a densely populated landlocked country, which complicates our ability to easily import and export goods relative to our neighbors by the sea. 2 decades ago, much of the world doubted that Rwanda was not a lost cause. The 1994 genocide against the Tutsi witnesses the death of nearly 1 million people. Our country was devastated, and nearly all the health sector was decimated. This month, it's an important one because it's the time for commemoration of the genocide against the Tutsi that took place 21 years ago in April 1994. And this is why I am staying in my country with my people, and I was not able to join you physically today. 21 years ago, Rwanda had the lowest life expectancy of any country in the world, only 27 years of age. As the health system was decimated, commitment and innovation were necessary to transform this story of hopelessness to a story of hope. I am speaking today to show how innovation, coupled with strong principles, have played a role in rebuilding our health sector and helping us to make progress in restoring and preserving the health of our children. We knew without growing our economy, it will not be possible to improve health, and vice versa. So we thought holistically about how we could best carry forth a vision that ensured no one was left out, no one was left behind, as we worked to rebuild the economy and the health sector. As you will see, we have come quite far over the past 2 decades. Rwanda has more than doubled its life expectancy, and economic growth has recovered as well as the two have grown together. This slide shows the rate of decline in child mortality by wealth quintile and area of residence. The Demographic and Health Survey 2010 data revealed that the greatest gain was seen among the most disadvantaged population, the poor and those living in rural areas. These data reflect how our policies and strategies reach all citizens and do not exclude anyone from the benefit they provide. It is our pillar. This has led to progress, and our country has reduced premature mortality from major infectious disease, ranging from HIV/AIDS to measles, over the past 2 decades. Since we introduced the rotavirus vaccines with voluntary uptake of more than 95%, the average reduction of childhood mortality has increased even further. This slide illustrates the gain we have achieved in child survival. The genocide against the Tutsi resulted in a huge increase of child mortality, followed by a dramatic decrease because we have taken actions after the genocide. Child mortality rates are now lower than what they were projected to be now in the pre-genocide period. And we are on track to converge with the global rates. This data, taken from an independent study, show that child mortality is not only linked to health expenditure. As shown in this slide, Rwanda has the greatest gain in child survival between 2000 and 2011 per US dollar invested across the world. So money is not the only explanation. Now, I'm going to discuss with you the 5 key principles that have helped Rwanda achieve this improvement over the past 2 decades. These 5 principles are the universal foundation of implementation science, and I hope you will apply them in your own work. All improvement started with the first principle, the shifting in your mindset. This led us to believe in ourselves, to think outside of the box, and to have faith in our future, taking energy in our traditional values. Just after the genocide against the Tutsi, there were some leaders in global health development who said incredibly damaging things. We have witnessed this so many times during the last 20 years. These statements are criminal and violate human rights by implying that the poor people in vulnerable situations can be denied the right to health, can be denied the right to live. By Maurice King's logic in 1994, we should simply have let our children die due to simple clinical conditions such as dehydration. Just read with me the following statement published by Maurice King in The Lancet in the year 90s. It states, merely because a technology such as oral rehydration exists, we do not have to introduce it in community in which the demographic trap is closing. How can this be done without adding to the many years of human misery? And blah, blah, blah. Can you imagine? First of all, it's a crime. We should have let our children die when we have a solution to keep them healthy and alive. Second, it's a failure of imagination to assume that we can't overcome difficulties of fighting poverty and disease, that we should just be fatalists and let our poor die. Numerous studies have provided evidence to the contrary. In fact, adherence to antiretroviral treatment for HIV is better in resource-limited countries than in many wealthy countries. And we know why. That's a different discussion that I'm ready to have with you another day. We see also that for vaccination, the rate is higher. Rwanda is an example, and much more. Just think about the recent measles outbreak in the US. This statement, such a statement, explains why we must innovate in global health to ensure that those with mindset that lack imagination are not leading us. And for myself, I am very proud to have contributed to proving them wrong by having made great improvement in our health sector to ensure our children live longer and healthier lives. Don't forget, global health starts where you are currently seated now. Having leadership that believe in health as a human right and part of the national vision is paramount. In Rwanda, the national vision is codified in national and sectoral strategies and laws and ensure that the right to health becomes a duty of states. Sound governance is critical for making this mindset shift because political will makes innovation the norms. One thing I'm very proud of in Rwanda is how leaders like me and others are held accountable for making progress. We are collectively charged to govern in a way that creates real and meaningful universal access to care. Similarly, our social cluster-based governance structure helps to ensure that we govern in a way that ministries of one cluster, and for me is the social cluster, are meeting regularly to discuss health as a collective issue. This holistic cross-sectorial approach ensures that insight from ministries of youth, gender, education, local government are fully taken into account in health policies and plan, and vice versa, that health in their plan are taken in account as well. It ensures that we are investing our dollar wisely to improve the health and well-being of the entire population, and that no one is left behind in outcomes that are achievable for all. This collaboration is not just across ministries in the social cluster, but also across all layers of government in Rwanda. You can see that non-communicable disease in this slide and major infection are cross-cutting issues in our economic development and poverty reduction strategy. This means that all governance entities are concerned with reducing disease burden and fulfill the human rights to health for all. We structure ourselves to work towards those goals and create policies that will ensure all institutions are set up to achieve them. So, in conclusion of the first principle, I encourage you to be somehow the people that start conversation to improve the world health as opposed to stopping them. Set ambitious goals because all human beings deserve the best. Believe that innovation can happen everywhere in the world, in Sweden as well as my home country, Rwanda. And also that we can all learn from each other. And know that the true experts of the population needs are the people themselves and that they deserve respect. The principle 2 has already been tackled somehow. It is the need to think about health beyond the health sector because health is multisectorial. The social determinants of health are influenced by sectors other than the health sector. This is why a multisectorial approach is so critical to keep a population healthy. We need transport for sick patients, educated personnel, adequate treatment facilities, food and housing, and partnership in global health for sharing resources and knowledge. These to name a few. Taking the example of vaccination in Rwanda, we are very proud that 90% of our kids are fully vaccinated for against 11 diseases. To achieve this, we need a good cold chain with electricity or solar energy. We need to secure transportation of goods across the country. We need an educated personnel to ensure adequate and timely procurement. We need a good waste management across the country. We need to educate parents to assure gender equity in voluntary vaccination. And we need partnership again to raise funds until the time we can pay with our own funds. For the time being, thanks to Gavi. Does this slide sound familiar? We need to work across all determinants of health and for the entire 8 MDG goal to improve the health outcome of our kids. We need to feed them. We need to put them at school. We need the parents to be educated. We need energy. We need to take care about the environment health, like with cook stove. You know that a mother cooking in a traditional way, in a room that has not enough air, with a baby in the back, the baby inhales the smoke so much that it's not good for its heart and its lung. So there is, and of course, if we do all this, we will improve child health, maternal health, and fight against HIV, TB, and malaria. So the 8 MDGs have to be tackled as one when we want good outcome for the health of our kids. For the principle number 3, I can summarize it as meeting people where they are. To explain this, I will highlight some of key pragmatic innovation in Rwanda that are helping us to meet people where they are physically and financially to assure that they have meaningful access to care. By meaningful access, we mean that the care provided is of sufficient quantity and quality. What is the value of providing too little high-quality care or too much substandard care? This is the pyramid that explains to you how care is delivered in Rwanda. The health system is organized as follows. Our 45,000 community health workers serve as our foundation. They are volunteers elected in their village, 3 per village. 2, we call them binôme. They care about 80% of the disease, and 1 a maternal assistant that follow all pregnancy and children under 3. So by doing so, we have bring care near the people. We are systematically create a health facility system to meet the demand for increasing complexity of care, but in a way that ensures that everyone can have equal access. You can see this commitment to the geographic equity to care delivery. We have the capital city with referral. We have 4 provinces with 1 provincial hospital. We have 30 districts and we have 37 district hospitals. Under the district, we have the sector, each with 1 health center. We still have 18 sectors where we need to build a health center. Below, we have the health post. We are now working on that level with the A2 nurse, and below the community health workers. This geographic equity approach has made an impact in our health outcome. We are now going to talk about the principle number 4. We can state like this: we must be creative in how we leverage vertical funding so that we strengthen the entire health system. By adapting disease-specific funding to build comprehensive health system, we can help ensure that $1 given today to improve the life of a new baby girl can also improve the care she will receive across her life cycle. This by consistently improve health system with each and every dollar we invest. It's good for a baby girl as well as for a baby boy. Look at this laboratory. We have built it with the funds for combating HIV/AIDS. It served HIV diagnostic and follow-up of treatment of the people living with HIV/AIDS, but it's also used to support newborn and children health for all patients. By creating health facilities, we are progressing, but it's not enough. We must ensure that we have qualified individuals in situations compatible to give quality care. We have a long way to go, and we are continuing to innovate. And in this area, we have a long way to go. I want to insist on that. We are creating partnerships to bolster our health workforce capacity, for example, because the lack of health professionals is a bottleneck to provide quality care. It is also necessary to be creative with task shifting to ensure that we are meeting patient needs with the little resources we have. We have created an innovative program called Human Resource for Health Rwanda, and we call it HRH program. It is a good example of how we use vertical funding for HIV to boost the entire health system. Through this 7-year partnership with 23 US academic institutions, we are addressing the workforce shortage that create the bottleneck to provide quality care by improving the capacity of our universities to produce qualified health workforce. In Rwanda, because the epidemiologic transition from infectious disease to non-communicable disease, we require to have new knowledge and resources. And the HRH program is one way in which we are addressing these challenges. Now we need to talk about improved financial accessibility to care. We have our Mutuelle de Santé for that and other health insurance. Mutuelle de Santé is a community-based health insurance program that covers 75% of the population. If we add to that number, the membership to other health insurance, we have nearly 82% of the entire population in Rwanda that has subscribed voluntarily to a health insurance for basic care. Given our commitment to ensure that no one is left behind, the government has mobilized domestic funds and partners to cover the cost for the 25 bottom poor of our country. So far, all participation in health insurance is on voluntary basis. We didn't enforce or make it mandatory. It's because we believe that we need to convince people that it's good for them to adhere to a health insurance. And this program has made a huge difference in accessibility to health for the entire population. The next slide is never do something without involving the people you work for. Community participation and ownership is key. It makes things happen. People get more involved in programs they believe in and that they believe will be good for their children. All of programs I have described before have got a really community ownership and in the care delivery. Rwanda fostered the participation process where everyone, from the village worker to His Excellency our President, feel that they can play a role in improving the health of their children. Let's talk about the principle number 5. For this one, I encourage all of you to be part of a learning health system. Know your epidemiology, know what affects your population, and improve the health system using evidence and science. In Rwanda, we managed to run the health sector using 13 software programs. This has allowed us to develop the health sector quickly despite the lack of human resources. These programs have decreased the transactional cost to provide care and allow us to understand the impact of program implementation. These programs are run using laptop and simple phone. Each community health worker, for example, is able to report every month. It's able to ask for advice or to call an ambulance using a simple phone that costs only $7. All our health facilities, we count 700 now, are using electronic reporting that allow us to capture data each month on the performance of our health system. This allows us to identify areas where we need to improve and where we should also invest the next available dollar. This is possible because Rwandan leadership has also been very innovative and visionary in their approach to developing a robust information and communication technology infrastructure across the entire country. Meaning now we can have access to internet in more than 90% of in Rwanda. So physical tool is something, but it's little if we don't do and invest in the people that will use them, who expect to improve by using them, and also who will probably create the next generation of tools that will help us to meet future health burdens. And for each of all those innovations, we always ask ourselves a question. How will this benefit to the most vulnerable in Rwanda? This helps us to remain true to our core values of ensuring that no one is left behind. In conclusion, we have discussed these 5 principles on how they have helped Rwanda to make progress in the way that has been fruitful for the health of our children and our entire population. We must also remember that our work is far from being over. In many ways, I can say it's only beginning. And that's why the call for innovation could not be stronger than today. And this is why I'm delighted to be speaking with so many bright brains that are in this room. And also, I have one message. Rwanda's story was not just some unexpected miracle. It is a useful example of what can be expected with strong principle and innovation based on human rights equity, on science, on participation, and sustainability. Thank you very much for your attention. Murakoze cyane.